Hey guys, Rebecca Basham here again. I am a PA. I've been a PA for over 14 years. I've worked in emergency medicine, family medicine, academia, and I'm the founder and creator of All Things PAC. We are a company, and our goal is to provide quality and affordable resources for PA students. Right now, that includes our All Things PAC Q Bank. We have a review course online associated with our Q Bank called PANCE Points. And then we now have, or in development, our All Things PAC PANCE Review, which you're watching right now. And we're going to go ahead and get started with today's video. We're going to be covering conduction disorders and dysrhythmias. We're going to go over that section of the blueprint. So we're going to go over each topic on the blueprint. We're going to go over practice questions. We're going to break this down in a easily digestible manner to help you understand it and succeed in this section of the PANCE. Let's get started. All right, before we dive in, I like to start by giving you a couple of practice questions. Now, the purpose of this is to check your knowledge and your confidence before we do the review. So I'm not actually going to go over the answers and explanations yet. After the review, we'll pull the questions back up again and then go over the answers and explanations together. So what I'd have you do now is when the questions come up here in a second, go ahead and pause the video so you have enough time to read the question. There will be 3 in total, and then we'll dive into the review. I also want to let you know at the end, I'll have a flashcard style quiz for you that will include all the dysrhythmias on the PANCE blueprint. All right, let's go. Okay, before you understand pathophysiology, it's always important to make sure you understand normal physiology. Conduction disorders are caused by dysfunction in the cardiac electrical system, which controls the heart's rate and rhythm. So before we go over the dysrhythmias, let's quickly review the normal conduction cycle. It starts in the SA node. This is the heart's natural pacemaker located in the right atrium. It initiates impulses at 60 to 100 beats per minute under normal conditions. With each depolarization wave, the impulse spreads outward from the SA node, causing atrial contraction. This is identified as the P wave on EKG. From the atria, electrical impulses travel to the AV node where there's a slight delay. The AV node acts as kind of a gatekeeper, slowing conduction to allow the ventricles time to fill with blood. The impulses then continue through the bundle of His and split into the bundle branches. And finally, the impulse ends at the Purkinje fibers, stimulating a ventricular contraction. Each of these steps correlates with different parts of the EKG. The P wave represents atrial depolarization, SA node to atria. The PR interval is the time during which the impulse travels through the atria and AV node. The QRS complex, as mentioned, is a ventricular depolarization where we have rapid conduction through the bundle of His. And then the T wave is ventricular repolarization. This whole electric system is influenced by the autonomic nervous system. Sympathetic stimulation increases heart rate and conduction velocity, while parasympathetic or vagal tone slows the SA and AV node conduction. The clinical relevance of all of this is that normal conduction maintains coordinated atrial and ventricular contractions, optimizing cardiac output. Dysrhythmias occur when this system is disrupted. Now, it can be disrupted from an impulse formation problem like atrial fibrillation or sick sinus syndrome. It could be an impulse conduction problem like AV block or a bundle branch block, or it can be a formation and conduction issue like Torsades or ventricular tachycardia. All right, now we're going to review each of the dysrhythmias that is on the PANCE blueprint. All right, our first one, everyone's favorite, atrial fibrillation. So AFib is a supraventricular tachyarrhythmia characterized by chaotic atrial electrical activity resulting in no effective atrial contraction. Basically, impulses bombard the AV node, resulting in an irregular, so you're going to see that come up a lot, irregular ventricular response. It's also the most common sustained arrhythmia, and prevalence increases with age. The classic EKG findings to note are an absent P wave and an irregular rhythm. So remember, absent P wave, irregular rhythm. It's often associated with a rapid heart rate between 100 to 180 beats per minute, but not always. Risk factors are going to include both cardiac and systemic problems. Our cardiac risk factors include hypertension, coronary artery disease, valvular heart disease, especially mitral stenosis and regurgitation, heart failure, and cardiomyopathy. Some systemic issues that are risk factors include hyperthyroidism, pulmonary disease, obesity, sleep apnea, alcohol consumption, which is sometimes referred to as holiday heart. Our clinical presentation often involves symptoms including palpitations, dyspnea, fatigue, dizziness, chest discomfort, or they'll say they just generally don't feel well. And on exam, you'll find their pulse has that irregular rhythm and possibly a variable intensity. It's also possible they could be hypotensive and unstable if they have a rapid ventricular response, so that really high heart rate. Sometimes, though, AFib is actually found incidentally and the patients can present asymptomatically. Talking about complications, the biggest complication we worry about is thromboembolism, which can cause a stroke. So essentially, the heart is quivering and occasionally a beat gets through, but since blood is not pumping effectively, it can become stagnant, and stagnant blood is not good. It can clot. Other complications include tachycardia induced cardiomyopathy, especially if it remains uncontrolled. And these patients can develop hemodynamic instability, which is obviously an emergency. Looking at management, acute management of atrial fibrillation depends on stability. Unstable, so that includes hypotension, chest pain, shock. This requires immediate synchronized cardioversion. We address stable AFib in one of two ways. First line is rate control, so trying to get that rapid rate down. We do this with beta blockers, non-dihydropyridine calcium channel blockers like diltiazem or verapamil, or digoxin is sometimes used if heart failure is present. The other option is rhythm control with antiarrhythmics or cardioversion. One of the most important parts of management of AFib is assessing thromboembolic risk and initiating anticoagulation for stroke prevention. Remember, these patients are often a high risk for stroke, very important. We do this by assessing a CHADS-VAS score, which assigns points for certain risk factors, including congestive heart failure, hypertension, looks at their age, diabetes status, whether they've had a previous stroke or embolism, whether or not they have vascular disease, and then the score determines whether or not anticoagulation should be started. We use oral anticoagulation, and the direct oral anticoagulants, the DOACs, are preferred. That includes apixaban and rivaroxaban. Now, in those patients with valvular disease and AFib, we use warfarin. Now, another management strategy is ablation. Ablation is usually reserved for symptomatic AFib that's refractory to rate and rhythm control, possibly used in younger patients if they wish to avoid long-term antiarrhythmic drugs that have potentially some adverse effects. However, you have to remember the stroke risk remains, so anticoagulation decisions are still based on using that CHADS-VAS score. All right, our next arrhythmia is atrial flutter. This is a rapid, regular arrhythmia due to a reentrant circuit, usually from the right atrium, so a single foci. This is associated with a very high atrial rate, usually around 250 to 300 beats per minute. However, the AV node only filters some of these impulses, and usually with the multiple. So, for example, one ventricular beat for every 2 or 3 atrial contractions. We call that a 2-to-1 block or a 3-to-1 block. This creates the sawtooth pattern that is easy to identify and regular, unlike the irregular, chaotic rhythm of AFib. The rest of the information is pretty simple because its presentation, complications, and management are all similar to that of AFib. So patients may present with palpitations, fatigue, generally not feeling well. Their risk factors are also going to be similar, including hypertension, heart failure, valvular disease, alcohol, etc. And a big one to remember, similar to AFib, is the increased risk of stroke. Management principles are also similar to that of AFib. So, for stable patients, we consider rate versus rhythm control with beta blockers and non dihydropyridine calcium channel blockers. But something to note for atrial flutter is that catheter ablation is often more effective than it is for AFib. Unstable patients are going to require synchronized cardioversion, and anticoagulation use is also guided by the CHADS-VAS score. Again, same as for AFib. So for atrial flutter, remember sawtooth waves with a regular rhythm, same anticoagulation rules as for AFib, and remember ablation has a higher long-term success rate for atrial flutter, especially compared to that for AFib. Next up is atrial tachycardia, which is another supraventricular tachyarrhythmia. It's characterized by rapid atrial impulses originating outside the normal sinus node, called an ectopic focus, and does not depend on accessory pathways, AV junction, or ventricular tissue for generation. It can be focal or multifocal, which we'll talk more about here in a second, and the EKG is going to show some characteristic features. So first, the QRS complexes are going to be narrow because the arrhythmia is supraventricular. The ventricles are still being activated though through the normal His-Purkinje system. Second, you'll notice a P prime wave. That's a P wave that looks different from a normal sinus P wave. It has a uniform but abnormal morphology since impulses are coming from an ectopic atrial focus rather than the SA node. And third, the atrial rate is usually between 150 to 250 beats per minute. This rapid atrial firing drives the rhythm. However, the ventricular rate may be slower depending on AV node conduction. And as I mentioned, atrial tachycardia can be focal or multifocal. In focal atrial tachycardia, the rhythm is driven by a single ectopic focus outside the SA node. On EKG, you'll see a regular, narrow, complex tachycardia with abnormal P waves that all look the same but different from the normal sinus P wave, and the PR interval is going to be constant. This can be seen in things like structural heart disease, digoxin toxicity, or after cardiac surgery. It's also frequently considered a benign condition. Now, multifocal atrial tachycardia is caused by multiple atrial foci firing. So instead of a regular pattern, you'll see an irregularly irregular rhythm with at least 3 different P wave morphologies on the same lead and variable PR intervals. Multifocal atrial tachycardia is classically associated with severe pulmonary disease, especially COPD. Now, clinically, both can cause palpitations, dyspnea, dizziness, or maybe asymptomatic. And management is going to depend on stability. So, for stable patients, vagal maneuvers, AV nodal blockers like beta blockers or calcium channel blockers. Adenosine can terminate some atrial tachycardias, but remember, not AFib or aflutter. Synchronized cardioversion should be used if the patient is unstable. And then catheter ablation may be considered for focal tachycardias if they're recurrent. Some key pearls to remember now for atrial tachycardia are the presence of discrete P waves that look different from the normal P wave. And remember, this also distinguishes it from AFib and aflutter where there are no P waves. It can be focal or non-focal. Digoxin toxicity is a classic trigger, and if you see irregular rhythm with at least 3 different P wave morphologies in a COPD patient, it's most likely multifocal atrial tachycardia. And then management is going to be the same as for other SVT rhythms, so vagal maneuvers, medications, and cardioversion if unstable. All right, next on our list is atrioventricular or AV blocks. These occur when conduction from the atria to the ventricles is slowed down or completely blocked. There are several types you need to be able to recognize, including first degree, second degree, of which there are 2 variations, Mobitz I and Mobitz II, and third degree or complete block. In first degree AV block, the key feature is a prolonged PR interval greater than 0.2 seconds, but every P wave still makes it through to a QRS. So the EKG will essentially look normal, but that PR interval will have a bigger than 1 square, so bigger than 0.2 seconds. First degree is usually benign and often doesn't need treatment. Next is second degree AV block Mobitz I II, also called Winky Bach. Here, the PR interval gets progressively longer and longer until a QRS is dropped. I'm sure you were taught the phrase longer drop. Now you have Winky Bach, which is pretty cute and helpful, but I also feel like this is the one that nobody has trouble remembering. What you see is a pattern that repeats itself. It's also often benign and usually doesn't progress. Another way, if you have trouble remembering if Winky Bach is type 1 or type 2, is that you wink with one eye. So Winky Bach is Mobitz I. In second degree AV block, Mobitz type 2, the PR interval is constant, but suddenly a QRS is dropped without warning. So it doesn't have the progressive PR interval, it just drops a QRS out of nowhere. This one is more serious because it often indicates pathology lower in the conduction system, and it can progress to complete heart block. So because of this, a pacemaker is often required. And finally, we have third degree, or also known as a complete heart block. In this rhythm, the atrium ventricles are beating independently of each other. The P waves have no relationship with the QRS complexes, and the ventricles have to rely on a slower escape rhythm to contract. And these patients are often symptomatic with dizziness, syncope, or hypotension, and they require pacing. So in summary, let's look at our pearls. First degree, prolonged PR, but benign. Mobitz I, Winky Bach, progressive PR lengthening until a drop, often benign. Mobitz II is a sudden drop. It can be dangerous and progress and usually needs pacing. And then third degree, a complete AV dissociation always needs a pacemaker. Next up is bradycardia, which is defined as heartbeat less than 60 beats per minute. And I'm going to keep this one concise because it's often tested in the context of sinus bradycardia versus an AV block and acute management for that, but we're going to go over just the basics here. Now, remember, not all bradycardia is bad. It's common in athletes and well conditioned people, even during sleep, because of higher vagal tone. In those cases, it's usually normal and not concerning. But bradycardia can also be pathologic. Cardiac causes include sinus node dysfunction and AV blocks, ischemia, like during an inferior MI. Non cardiac issues include things like hypothyroidism, hypothermia, electrolyte problems, and certain medications, especially beta blockers, calcium channel blockers, digoxin, and some antiarrhythmics. Patients may be totally asymptomatic, or they may present with symptoms like fatigue, dizziness, syncope, chest pain, shortness of breath, hypotension, or even altered mental status if the heart rate is too low to maintain cardiac output. On the EKG, you'll see a sinus rhythm with a rate under 60 beats per minute if it's sinus bradycardia, or you may see an AV block pattern. Always check for reversible causes with labs, a medication review, and look for ischemia. The management will depend on stability. If the patient is stable and asymptomatic, you may not have to do anything except address the underlying cause. But if the patient is unstable, meaning hypotension, syncope, chest pain, shock, you have to act quickly. The first line treatment is atropine, given IV, up to a total of 3 milligrams. If atropine doesn't work, move to transcutaneous pacing or IV infusion of dopamine or epinephrine. And if the bradycardia is persistent or due to an irreversible condition or problem, the definitive treatment is a pacemaker. So our pearls to remember here are sinus bradycardia can be normal in healthy young adults and athletes. We want to rule out reversible causes because this often fixes the bradycardia. And then atropine is used for unstable patients, and if that fails, go to pacing or your pressors. Okay, guys, we're moving right through the conduction disorders, and we're now on to bundle branch blocks. So these happen when conduction through either the right or left bundle is delayed, which on the EKG will show up as a wide QRS, so greater than 120 milliseconds. We're going to look at right bundle branch blocks first and then left. So one thing to note about right bundle branch blocks is that in healthy patients, these are fairly common and generally not worrisome. But you should be aware they can also occur in things like structural heart disease or in the setting of increased right ventricular pressure. So for example, a pulmonary embolism. If it's a right bundle branch block, you'll see the classic, of course, widened QRS, but the key feature is an RSR prime pattern in V1. We call them rabbit ears. And in the lateral leads, so 1, AVL, and V6, you'll notice a wide slurred S wave. On the other hand, left bundle branch blocks are almost always pathologic. It's usually due to coronary artery disease, hypertension, or cardiomyopathy. If it's a left bundle branch block, you won't see rabbit ears. Instead, in V1, you'll find a deep, wide S wave. And in the lateral leads, so 1, V5, and V6, you'll see a broad, often notched R wave. Now, something very important to remember is that left bundle branch blocks make it difficult to interpret ischemic changes. So, if a patient has a new left bundle branch block in the setting of chest pain, you treat it like a STEMI equivalent. So, in summary, if you see a wide QRS and you want to figure out if it's a right or left bundle block, start by looking at V1 and V6. If there's rabbit ears in V1, you have a right bundle branch block. Broad, notched R waves in the lateral leads, you have a left bundle branch block. Management for these involves treating the underlying cause. Remember, isolated right bundle branch blocks usually require no treatment, but for left bundle branch blocks, you have to evaluate for structural heart disease or ischemia. So always remember, left bundle branch blocks in the setting of chest pain is a STEMI equivalent, and you have to treat as an MI or acute coronary syndrome. Okay, our next one on the blueprint is idioventricular rhythms, which we're not going to spend a lot of time on because honestly, there's just not that much to talk about, but I'll hit on the highlights just because you may see something on your boards or in your studies. So again, we'll just touch on the highlights. So this is a slow heart rate originating from a ventricular escape beat when the SA or AV node fails to pace the heart. We have to rely on the pacers in the ventricle. That's going to show up in the EKG as a wide QRS, again, because it's ventricular in origin, and also because it's ventricular in origin, we're going to have no P wave. And the rate is going to be very slow, 20 to 40 beats per minute only. So some potential causes include AV dissociation, MI, especially during a reperfusion stage of thrombolytic therapy. So that's kind of your board pearl there is during reperfusion, seeing a ventricular rate and rhythm. And then electrolyte abnormalities, some medication toxicities can also be culprits. Some clinical scenarios where you might see this. I just mentioned this one, an acute MI, especially during that reperfusion state after thrombolytic therapy, advanced AV block, and end stage heart disease. So, management wise, we want to treat the underlying cause. So, why is the SA node and the AV node failing? If they are unstable, once again, we're going to look to use atropine or pacing if needed. And then remember that accelerated IVR during the reperfusion state, so during an MI, during reperfusion, that's generally transient and benign. And something to keep in mind is you don't want to use antiarrhythmics in that situation because it can actually suppress the escape beat and cause asystole. All right, we're going to talk now about junctional rhythms, and this one's going to be brief as well. So these occur when the AV junction, that's the AV node in His bundle region, take over as the pacemaker because the SA node isn't firing properly or the signal just can't get through. It's going to consist of having 6 or more consecutive junctional escape beats. And the rate tells you the type of junctional rhythm. So a junctional escape rhythm is 40 to 60 beats per minute. If it's slower, under 40, we call that junctional bradycardia. If it's faster, 60 to 100, that's accelerated junctional rhythm. And if it's over 100, we call that junctional tachycardia. So on the EKG, the QRS complexes are actually narrow, and that's because the ventricular conduction is still traveling through the normal His-Purkinje system. The key finding is going to be inverted P waves. And depending on the timing, you may see an inverted P wave before the QRS, an inverted P wave after the QRS, or sometimes there's no visible P wave at all if atrial and ventricular depolarization are happening simultaneously. So our pearls to remember here with junctional rhythms are a narrow QRS with an absent or inverted P wave. That's junctional rhythm. And in terms of management, junctional escape rhythms are protective. This is an important thing to remember. So if the patient is stable, we don't try to suppress them. Instead, we treat the underlying cause. Now, if the patient is unstable with bradycardia, we're going to follow those usual bradycardia algorithms with atropine first, then pacing, or dopamine epinephrine infusion if needed. Another pearl here with junctional arrhythmias is digoxin toxicity is a classic cause. So if it's related to that, the priority is going to be treating the toxicity. All right, continuing along through the blueprint, we're now going to talk about premature contractions. Now, these are extra beats that occur earlier than expected in the cardiac cycle, and they can come from the atria, the AV junction, or the ventricles. We're going to focus on ectopic beats from the atria and ventricles. Those originating from the atria are called premature atrial contractions, or PACs, and on the EKG, you'll see an early beat with an abnormal P wave morphology because it's coming from an ectopic atrial focus, not the sinus node. The QRS complex is still narrow since conduction goes through the normal His-Purkinje system. Now, one high-yield feature is the pause after the PAC. What happens is a PAC fires early from an ectopic atrial focus. The premature P wave still conducts through the AV node unless it's blocked. Because the sinus node is reset by the premature atrial impulse, the next sinus beat comes earlier than expected. The result is what's called a non-compensatory pause after the PAC because it's shorter than a full compensatory pause. So in simple terms, the PAC resets the SA node timing, so the sinus node fires earlier than it would have otherwise. Next, and probably more clinically significant, are premature ventricular contractions, or PVCs. These arise from the ventricles, so the QRS is wide and kind of bizarre looking with no preceding pre-wave. The next sinus beat arrives as scheduled, but the ventricles are still refractory from the PVC, so that sinus beat doesn't produce a QRS. They're usually followed by a full compensatory pause because the next sinus beat arrives as scheduled, as I just mentioned. PVCs can be unifocal, where they all look the same, or multifocal, where they look different because they're coming from different ventricular foci. And PVCs can occur in patterns. Bigeminy is where every other beat is a PVC. Trigeminy, every third beat is a PVC. They can also occur in couplets or triplets, which are back-to-back PVCs in a set of 2 or 3 in a row. When you have more than 3 PVCs in a row, that's technically considered a run of ventricular tachycardia. Clinically, premature contractions can be triggered by stress, caffeine or other stimulants, electrolyte abnormalities, underlying heart disease. And PACs and occasional PVCs are often benign in healthy patients, but frequent PVCs, especially in someone with structural heart disease or after an MI, are concerning because they can progress to ventricular tachyarrhythmias. Management is going to depend on symptoms and context. So, asymptomatic patients usually don't need treatment. For symptomatic PACs or PVCs, start with lifestyle changes. Cut back on caffeine and stimulants, correct electrolyte abnormalities if present. Beta blockers may be helpful if symptoms persist. If premature beats are frequent in the setting of structural heart disease, they warrant further evaluation. And if the patient becomes unstable or degenerates into sustained arrhythmias, follow the ACLS protocols with cardioversion or antiarrhythmics. So our key pearls to remember here are PACs have a narrow QRS, abnormal P wave, and a non-compensatory pause, while PVCs have a wide, bizarre-looking QRS with no P wave and a full compensatory pause, and may occur in bigeminy, trigeminy, or couplets. Remember, isolated premature contractions are usually benign, but in the right clinical context, they can be a warning sign for something more serious. All right, our next dysrhythmia is QT prolongation. We define this as a QT interval greater than 440 milliseconds in men or 460 milliseconds in women. Some sources will use 500 milliseconds as a clear abnormal cutoff. The QT interval reflects ventricular repolarization, and when it's prolonged, the big risk is developing Torsades de Pointes, or a form of polymorphic ventricular tachycardia, and we'll actually be discussing that one here in a bit on its own. There are both congenital and acquired causes. Congenital long QT comes from genetic conditions we usually refer to as inherited long QT syndromes, but most cases are actually acquired due to medications or electrolyte disturbances. Medications include some antiarrhythmics, some antibiotics, and some psychiatric medications, of which some of them are listed here. Electrolyte causes include hypokalemia, hypomagnesemia, and hypocalcemia, and bradycardia itself can actually prolong the QT as well. Many patients are asymptomatic until something happens. Others may present with palpitations, syncope, seizure-like activity, or even sudden cardiac death, often because it has progressed to torsades. On the EKG, you'll see a prolonged QT interval. There is a calculation called the QTC interval that takes heart rate into account. Remember, the rule of thumb is the QT should be less than half of the RR interval. If it's longer, that's considered prolonged. Our management starts with removing the cause, so we want to stop any offending agents and correct any electrolyte abnormalities. In congenital long QT, beta blockers are often used to reduce the risk. So here are our pearls. A QTC over 500 milliseconds is considered high risk for torsades. Always check medication lists when you see a patient with unexplained syncope or arrhythmias. Magnesium is a drug of choice for torsades, which we'll talk more about later. And congenital long QT is managed with beta blockers and sometimes, depending on the risk, an implantable ICD. Our next one is sick sinus syndrome, which is not as easily testable, but you should still be familiar with what it is, which is simply dysfunction of the SA node. Instead of firing regularly, the sinus node is unreliable. Sometimes it fires too slowly, sometimes it pauses, and sometimes it alternates with episodes of rapid atrial arrhythmias. And that's why you'll hear the term tachybrady syndrome. The most common cause is age-related fibrosis of the SA node, but it can also be triggered by medications like beta blockers, calcium channel blockers, and digoxin, as well as conditions like hypothyroidism. Many patients are asymptomatic, but when symptoms do occur, they include dizziness, fatigue, palpitations, syncope, or pre-syncope. On EKG or a Holter monitor, you may see sinus pauses, sinus arrest, or alternating brady and tachyarrhythmias. Management starts with correcting any reversible causes, like stopping offending medications. But for patients who are symptomatic, the definitive treatment is usually a permanent pacemaker. So the pearls here: an older patient with syncope and alternating brady and tachyarrhythmias on EKG thinks sick sinus syndrome, and the treatment is a pacemaker. All right, our next one is sinus arrhythmia, which is also going to be short and sweet. And that's because while it sounds like it should be abnormal, it's actually just a normal physiologic finding. It happens because the sinus node is influenced by changes in vagal tone during breathing. During inspiration, vagal tone decreases and the heart rate speeds up just slightly. During expiration, vagal tone increases and the heart rate slows down. So in the EKG, you'll see a normal sinus P wave before each QRS, but the RR interval varies in regular pattern with respiration. It's most commonly seen in children and young healthy adults, and it doesn't require any treatment. So the pearl here is sinus arrhythmia is a normal respiratory variation in heart rate, not a pathological rhythm. All right, our next one is Torsades de Pointe, and this one should look familiar because we've already talked about prolonged QT syndrome, and these are closely related. So this is a specific type of ventricular tachycardia that occurs when the QT interval is prolonged. The name means twisting of the points in French, and that describes the EKG. The QRS complexes change shape and seem to sort of twist around the baseline. On the EKG, it looks like a wide complex tachycardia with polymorphic QRS complexes. So in other words, the QRS shape keeps changing, and the tracing has that classic twisting appearance I mentioned. The most important thing to remember is that torsades is always linked to a prolonged QT interval. Causes include medications that prolong the QT, so certain antiarrhythmics, antibiotics, antidepressants, and antipsychotics, as well as electrolyte abnormalities like hypokalemia, hypomagnesemia, and hypocalcemia. Congenital long QT syndrome can also predispose to torsades. Clinically, patients may present with palpitations, dizziness, or syncope. It may stop on its own, but it can also deteriorate into ventricular fibrillation and sudden cardiac death, so it is always taken seriously. For management, the treatment choice is intravenous magnesium sulfate, even if the magnesium level is normal. If the patient is unstable, you go straight to defibrillation and always address the underlying cause. Stop offending medications, replace electrolytes, and in recurrent cases, you may need overdrive pacing or isoproterenol to shorten the QT. So here are our pearls. Torsades is a polymorphic ventricular tachycardia associated with prolonged QT. Magnesium is a first-line treatment, and if unstable, defibrillate immediately. All right, guys, we're moving through these arrhythmias, almost done. Our next one is ventricular fibrillation or VFib, one of the most critical arrhythmias you'll see, definitely testable. VFib is essentially chaotic electrical activity in the ventricles. Instead of organized depolarization, the myocardium is essentially just quivering without producing any coordinated contraction, so it's not really beating. That means there's no effective cardiac output and the patient is in full cardiac arrest. On the EKG, VFib looks like a totally irregular, squiggly line. There are no P waves, no QRS complexes, and no T waves, just chaotic, disorganized activity. The most common cause is ischemic heart disease, especially acute myocardial infarction. Other causes include cardiomyopathy, myocarditis, electrolyte disturbances like hyperkalemia or hypokalemia, certain drugs like antiarrhythmics, digoxin, which always seems to show up, severe hypoxia, or trauma. Clinically, the patient will be unresponsive, pulseless, and apneic. It can happen suddenly, sometimes right after chest pain, syncope, or palpitations. Management is immediate. According to ACLS guidelines, the treatment is unsynchronized defibrillation right away. Don't wait, don't delay. If the patient has VFib, you shock them. At the same time, provide high quality CPR, give epinephrine every 3 to 5 minutes, and consider amiodarone or lidocaine if VFib persists after shocks. And of course, always think about and correct reversible causes. Look at your H's and T's, which are mentioned here. So, the big pearls VFib equals cardiac arrest. The treatment is immediate defibrillation plus CPR. This is not synchronized cardioversion, it's unsynchronized defibrillation. That's ventricular fibrillation. Recognize it and treat it immediately. Okay, guys, we're in our last final dysrhythmia on the PANCE Blueprint, and that is ventricular tachycardia or VTAC. This is a dangerous arrhythmia that originates in the ventricles and produces a wide, complex tachycardia. On the EKG, VTAC shows a wide QRS complex greater than 120 milliseconds, usually with a regular rhythm. It could be monomorphic, where all the QRS complexes look the same, or polymorphic, where they vary in shape, like Torsades de Pointe. Sometimes you'll even see AV dissociation, capture beats, or fusion beats, which help confirm VTAC. Clinically, the presentation depends on whether the patient is stable, unstable, or pulseless. Stable VTAC may cause palpitations, dizziness, shortness of breath, or chest discomfort. Unstable VTAC with a pulse causes hypotension, syncope, altered mental status, or shock. And pulseless VTAC is cardiac arrest. It's treated the same way as ventricular fibrillation. The most common underlying cause is ischemic heart disease, especially myocardial infarction, but other triggers include cardiomyopathy, electrolyte abnormalities like low potassium or magnesium, and drug toxicity. Management depends on stability, and again, we're going to go back to the ACLS algorithm. If the patient is stable with a pulse, give antiarrhythmics, most commonly amiodarone, but procainamide or lidocaine are also options. If the patient is unstable but still has a pulse, the treatment is immediate synchronized cardioversion. And if the patient is pulseless, the treatment is immediate unsynchronized defibrillation with CPR, just like ventricular fibrillation. Okay, and our pearls for our last rhythm, which is VTach, is that it's a wide, complex, regular tachycardia originating from the ventricles. If you see VTach, you have to determine is the patient stable or unstable. So look at their physical exam signs of perfusion, their blood pressure, and then do they have a pulse or are they pulseless VT? Amiodarone if they're stable, cardioversion if they're unstable, and defibrillation if they're pulseless. All right, guys, remember at the beginning of this video, I know it was a long one, but we had a lot of arrhythmias to go through. I gave you 3 PANCE style board questions. I'm going to give you those again. And remember, what we're going to do is I'm going to put the question up. You need to pause the screen to make sure you have time to read it. It's only going to be up for about 5 to 10 seconds. Pause it, see if you can now come up with the answer, and then we'll go over the answer together. We'll do that 3 times. And then make sure you stay tuned. At the very end, I'm going to give you a quick kind of flashcard style quiz of all the arrhythmias we went over. Okay, here's question 1. Don't forget to pause your screen and make sure you have time to read the question. All right, I know this one may seem a little easy, but you are guaranteed to see AFib on the PANCE. And a lot of rhythm questions, cardio questions will have a long question sim, a long vignette. Don't let that throw you off. Look for your key clues here. This is an older lady with symptoms of, a dysrhythmia. She's got palpitations, shortness of breath. We also see that she is tachycardic and that she has an irregular rhythm. And we know that that is classic for AFib. Again, the hallmark of AFib is an irregular rhythm without P waves. So hopefully you guys got this one. Let's go on to question 2. Again, don't forget to pause your screen. It's only going to be up for about 5 to 10 seconds, and then we'll go over the answer. Well, this gentleman unfortunately has a 3rd-degree AV block, otherwise known as a complete heart block. So once again, we see these sort of vague symptoms that are associated with dysrhythmias. He's got fatigue, lightheadedness. He's also got those risk factors for coronary artery disease and a previous MI. But also pay attention here. His pulse is very low. His bradycardic and his blood pressure is also low. So he's getting relatively unstable. And if we look at that rhythm strip, the key here is that the P waves are running independent of the QRS waves. Some of the QRS waves, they don't consistently have a P wave before them. If you look at them, the QRS waves are doing their own thing. The P waves are doing their own thing. There's complete AV dissociation. The atria and the ventricles are running completely independent of each other. And this is diagnostic of a 3rd-degree AV block or complete heart block. Okay, on to the next question. Don't forget to pause here, give yourself time to read the question, and then we'll review the answer together. All right, hopefully you got this one because we just went over it last, but this is VTach. This person is presenting unresponsive. They are unstable. You look at the monitor and you see that classic VTach pattern. What do we do next? So remember with VTach, you have to determine is the patient stable, unstable, and do they have a pulse? The patient in this question does not have a pulse. And so what do we do with VTach without a pulse? We treat it just like VFib. And that means that you're giving an immediate unsynchronized defibrillation. Not synchronized cardioversion, that's for unstable but perfusing or tachycardia with a pulse. This is unstable without a pulse, treat like VFib with an immediate defibrillation. Okay, those are our questions, but I also told you I'd be giving you a quiz. What I'm going to do next, I'm not going to talk through these. We're going to do the same thing. I'm going to give you each of the rhythms that we went over, the dysrhythmias and conduction disorders, each one of them that are on the blueprint. I'll have each one of them up with a little bit of a case study, just a brief kind of scenario. Have it on for 5 to 10 seconds. So make sure you pause it if you don't immediately know, and then I'll give you the answer in the next one. And these will be kind of rapid fire without me talking. And then that will conclude the conduction disorders and dysrhythmias section of this review. Thanks, guys, for hanging with me. I know this was a long one. All right, guys, thanks for hanging with me through this long video going over all the conduction disorders and dysrhythmias. Hopefully, you found it helpful. Hey, if you haven't checked out any of our resources, we have a comprehensive Q bank. We have a comprehensive review course that's a bullet point style, kind of highlight, high yield information about every topic on the PANCE Blueprint. That's all one combination called PANCE Points plus Q bank. We also sell a full length mock PANCE exam that's 300 questions, comes with answers and explanations. So if you haven't checked out those resources, make sure and look at those, and we'll see you on the next review video.